My name is Dr. Richard Horowitz, and it's a pleasure to be here with you today. I did my medical training at the Free University of Brussels in Belgium between 1977 and 1984. And then I returned home to do my internal medicine training at Mount Sinai Medical Center in New York City and Elmhurst, New York. At which point, I became a board-certified internist and moved upstate to the Hudson Valley, where I was moving into one of the most Lyme endemic areas in the United States. I have now seen over 12,000 people who've been diagnosed with chronic Lyme disease, who come to me from all over the United States and who come to me from Europe. I've had patients come to me from Belgium who are extremely sick, from France, from Norway, from other parts of Europe. And I can tell you that this is a worldwide epidemic. It is very poorly understood. It's causing tremendous suffering, and it is my great pleasure to be able to share this information with you so I can help the Belgian people and repay the great kindness that you showed me when I was doing my medical training in Belgium. Today I'm going to be discussing Lyme disease and multiple systemic infectious disease syndrome, otherwise known as MSIDS. This is a new paradigm for the diagnosis and treatment of chronic illness. The problem that we face with Lyme disease for the moment is that many people do not believe in the existence of chronic Lyme disease. As you can see from this particular cartoon, the bad news is you have Lyme disease, but the good news is I don't believe in that disease, so you're fine. And this is the problem that I face, as many people do not realize how serious this problem of Lyme disease is in the United States, that it's spreading throughout Europe, and is also spreading worldwide. Lyme disease is the #1 spreading vector-borne epidemic worldwide. The CDC just came out with figures in 2013 that showed us that there was a 10-fold increase in the number of cases. We went from 30,000 cases to 300,000 cases, and in fact, the figures are even worse. If you look at the figures reported by the CDC, 0.3% of the American population in 2012 was exposed to Lyme disease, which is approximately 1 million people in the United States. Lyme disease, which is an infection caused by Borrelia burgdorferi, which is a spirochete, and other borrelial species, are spreading across Europe, as are other tick-borne diseases such as babesiosis, Bartonella or cat scratch fever, and many other infections that I'm going to tell you about, and they're mimicking many different illnesses. There is a lot of confusion now regarding the diagnosis and treatment of Lyme disease due to two standards of care that exist in the United States, one by the Infectious Disease Society of America, or IDSA, or ILADS, the International Lyme and Associated Disease Society, of which I was a founding member. We're going to be discussing today how we define chronic Lyme disease. What exactly is it? And I'm going to show you that there is a difference between the surveillance definition established by health departments and what we see in real life in the doctor's office. And I'm proposing to you a new definition called Lyme MSIDS, which stands for Multiple Systemic Infectious Disease Syndrome, which will better define the illness. And I will show you that there are up to 16 reasons why many of these people stay ill with chronic Lyme disease, and this is not well reported in the scientific literature. There are also problems with diagnosing Lyme disease. As I will show you, there are problems with serology and seronegative infection, where patients will come in and see me and have Lyme disease, but the standard blood tests are negative. And I'm going to suggest to you later in this presentation that one of the best ways to address this is by creating country-specific Western blots using the strains of Borrelia that you have in Belgium and in the European countries. As far as treating Lyme disease, there is evidence of persistent chronic borrelial infection and the need for longer treatment courses. And there is some new scientific evidence that has come out showing that Lyme persists and that we do need longer courses of antibiotics. Chronic infection from Lyme and associated tick-borne diseases will cause inflammation in the body. And inflammation is the #1 common denominator in all chronic diseases. And this can lead to symptoms of chronic fatigue, musculoskeletal pain, cognitive difficulties, sleep disorders, and neuropsychiatric symptoms. So for example, when we look at the figures for chronic disease in the United States, we see that 75% of our healthcare costs are due to chronic disease, and 70% of the deaths in the United States are due to chronic illness. So this is very important that we understand how the MSIDS model can help us also with chronic illness. This multifactorial model for chronic diseases called MSIDS, Multiple Systemic Infectious Disease Syndrome, will be discussed in detail today, showing you how multiple factors on the MSIDS map are responsible for disabling symptoms in my patients. An application of this model will ultimately help us to decrease suffering and associated healthcare costs associated with tick-borne diseases. We're also going to be discussing prevention, education, and research. We will be discussing determining the incidence of Lyme and associated tick-borne diseases in Belgium, and I'm going to show you how to use a screening questionnaire that is in my book to screen patients for Lyme and associated tick-borne disorders without the associated costs of going to a laboratory. We will also be discussing the need of screening the ticks in Europe and in Belgium for Borrelia burgdorferi, as well as other Borrelia species, because now we have other Borrelia species showing up in the ticks, such as Borrelia miyamotoi, the relapsing fever spirochete. In Europe, you have Borrelia afzelii that causes acrodermatitis, chronica matrophicans, and Borrelia guarini that causes neuroborreliosis. But there are other borrelial species that may not show up on standard Western blots, such as Borrelia valsana, Borrelia lusitania, Borrelia spilmani. And there are other associated tick-borne infections that are also now spreading worldwide, such as Ehrlichia, Anaplasma, Babesia, including many species of Babesia, such as Babesia microti, Babesia duncani Wa1, and Babesia divergens, which is in Europe, as well as several different Bartonella species and rickettsial species. So we're going to talk about screening for these different species, screening pregnant women because it can affect the fetus and cause fetal morbidity and mortality, and screening the blood supply, because some of these tick-borne infections, such as Babesia and Anaplasma, have now entered the blood supply, and you can get these infections after a blood transfusion, and you may not be screening for this in Belgium at this point in time. There is a 16-point map that I have developed for treating patients who come to me with chronic Lyme disease, and I call this map the Lyme MSIDS map. It is as if someone went into a doctor's office with 16 nails in their foot saying to the doctor, "Doctor, I have foot pain." And the doctor only found 2 nails in the foot, pulled it out, and the patient returned to the doctor saying, "I still have foot pain." The problem is the doctor did not identify all the nails in the foot. What you see here with this MSIDS map are the 16 nails that can be in someone's foot causing pain. So for example, the first point on the map is infections, which is developed into 4 different categories. The first is bacterial infections, which includes Lyme disease, ehrlichiosis, Bartonella, mycoplasma, chlamydia, Rocky Mountain spotted fever with other rickettsial infections such as typhus, and Q fever, tularemia, and even tick paralysis. There are then parasites that are showing up in the ticks, such as Babesia and other pyroplasms. There's filariasis and amoebiasis that sometimes shows up in my patients, as well as giardiasis. So we need to screen for different parasites, which are not all coming from ticks, but which still cause patients to be ill. Then there are viral infections, some of which may reactivate when patients get chronic Lyme disease, such as Epstein-Barr virus, herpes virus 6 or 8, cytomegalovirus. And then there are mosquito-borne viruses like West Nile, which show up in my patients. The Heartland virus, which was recently reported 2 years ago in the New England Journal of Medicine, and the Powassan virus, which can cause a very severe encephalitis, as well as other viral encephalopathies. And finally, we find Candida and other fungi in our patients, whether they've taken antibiotics or whether they've had it before coming to see us. So when someone presents with Lyme disease, my patients don't usually just have Borrelia burgdorferi. One of the main reasons that they've stayed ill is because they have multiple associated tick-borne infections, as well as other infections simultaneously. And if you do not treat them all at the same time, these people will not get better. We also find that there's immune dysfunction. You get an overstimulated immune function with Lyme disease. These people will have false positive anti-nuclear antibodies looking like lupus. or false positive rheumatoid factors, where the doctor may tell the patient that they have rheumatoid arthritis. They may have markers, such as HLA-DR2 or DR4, that are positive, meaning that they're going to have more severe autoimmune manifestations. We find that when we treat Lyme and co-infections, many of these immune markers get better. The third point on the MSIDS map is inflammation. These tick-borne infections will cause a tremendous inflammatory response in the body. You get an increase of inflammatory molecules called inflammatory cytokines, interleukin-1, interleukin-6, tumor necrosis factor alpha. All of these will be increased in the body and cause something called the sickness syndrome, which means that when people get these inflammatory molecules secreted from these organisms being in their body, they get headaches, they feel tired, they get brain fog and memory problems, mood disorders, they get muscle pain and joint pain. These are all from these inflammatory molecules called cytokines, and I will show you later on in the presentation that even if we don't kill every last spirochete in the body, but simply lower all of these different co-infections and Lyme, the load of the organisms, we can make people better by decreasing inflammation in the body. The fourth point on the map is toxicity. Many people now come to me and they have multiple chemical sensitivity or environmental illness. What this means is that we're getting 300 to 500 chemicals coming in every day into our bodies, and some people are very sensitive to these chemicals. Heavy metals like mercury and lead that get into the body. So in some of my patients, when we deal with these toxins and open up the detox pathways and detoxify them, many of these patients feel better, and this is one of the clues that's very important, that it's not all about just hitting infections and lowering down the load of the infectious agents. It's also about opening up the detox pathways and getting rid of some of these toxins from the body. The fifth point on the map is allergies. If you have food allergies, and not just IgE food allergies, which is an immediate sensitivity to a food, for example, you eat nuts and your throat swells up. We're talking about food allergies where you have a sensitivity and it's a delayed reaction to a food, where you get these same inflammatory molecules that are produced that will also cause fatigue, headaches, and joint pain. And we find that if we screen people for some of these food allergens and sensitivities and have them eliminate them from the diet, some of their Lyme symptoms also may get better. The sixth point on the map is nutritional and enzyme deficiencies, or functional medicine abnormalities in biochemical pathways. Approximately 25% of the people who come to see me are nutritionally deficient. They may not have enough zinc. Now, if you don't have enough zinc, you're going to get more inflammation in the body. 25% of these patients also don't have enough iodine to make thyroid hormones. They may not have enough copper, which is necessary in an enzyme called superoxide dismutase that deals with free radicals and oxidative stress. So if you do not have the proper nutritional supplements and a proper diet, you will not be able to deal with inflammation and free radical oxidative stress in the body. The seventh point on the map is mitochondrial dysfunction. There are parts of the mitochondria that are affected by these free radicals and inflammatory molecules. If your mitochondria are affected, you're going to be tired. Your nerve pain may get worse. So some people need to have nutritional support with enzyme CoQ10, with acetyl L-carnitine, with NT factor, glycosylated phospholipids. And when you replace some of these nutritional deficiencies and get the mitochondria working correctly, some people, their energy and their nerve pain, and generally their symptoms will get better. The eighth point on the map is psychological disorders. Many people will go to 10 to 20 doctors being treated for Lyme disease and say that they don't get better, or go to dozens of doctors who will tell them they simply have chronic fatigue syndrome or fibromyalgia. And these people ultimately are diagnosed with PTSD because they're said there's nothing wrong with them, it's in their head. But these people are sometimes treated very badly by the medical system because the tests are unreliable and they're told that there's nothing wrong with them. Many people also have had difficult childhood and abuse. So if you have had emotional stress, physical abuse, so we find that we also have to support these people through their illness and use either medication or natural products, or have them go into therapy to help them. The 9th point on the map is neurological dysfunction. Many people with Lyme disease get a tremendous amount of neurological problems. They get headaches, visual problems where the visual changes. One day it's fine and the next day they can't see well. They get dizziness, light sensitivity, sound sensitivity, memory and concentration problems. And this can affect children where they go to school and because of their neurological deficits, they don't do well in school. Now, this is a big problem worldwide for children because this is the future generations of the world, and Lyme is getting into the children in this spreading epidemic, and we'll talk further about these neurological problems later. The 10th point on the map is endocrine disorders. Lyme will affect the endocrine system because these inflammatory molecules will affect the pituitary gland, the master hormone of the body. So when the pituitary is affected, you may find that, for example, you have low adrenal hormones. If your adrenal hormones are low, you're tired, and you can't possibly respond to these infections in the same way. And many doctors do not check for endocrine disorders. They do not check for low adrenal. And you would not normally think in a 20 or a 30-year-old man who comes in saying they're tired and they have no libido or sex drive, you would normally not think to check a testosterone level. But I found that several of my patients with Lyme disease, who are men, will come in with low testosterone as if they were 70 or 80 years old. So you also have to balance out the thyroid, the adrenals, and the sex hormones in patients with Lyme disease, or they will not feel better. The 11th point is sleep disorders. Patients with Lyme disease will come to me and tell me they cannot fall asleep, they keep waking up in the middle of the night, and they have an unrefreshed sleep. They don't feel well when they wake up in the morning. Lyme disease causes tremendous sleep disorders, and even classical drugs like Ambien, Lunesta, drugs that usually would work for sleep, do not work in many of these patients with Lyme disease. So sleep disorders are important to deal with because if you do not get the Lyme patients to sleep, this inflammatory response in the body, producing these inflammatory cytokines, specifically IL-6, will be produced, and these patients will say, I'm tired, I'm achy, I have headaches, my memory doesn't work, because you have lack of sleep and inflammation in the body. The 12th point on the map is autonomic nervous system dysfunction. The autonomic nervous system is the part of the body that deals with blood pressure, heart rate, bowel function, bladder function. And we find that many of these patients who come to see me who say, Doc, I'm tired, I'm dizzy, I have memory problems. It's not all just from the infection, but from low blood pressure. So for example, if you stand these people up in a medical office, you will find that after several minutes, their blood pressure drops, their heart rate goes up, and they start to feel dizzy. And if you address this autonomic nervous system dysfunction, and you raise their blood pressure and balance the autonomic nervous system dysfunction, many of these people who have POTS, or postural orthostatic tachycardia syndrome, which is a part of the autonomic nervous system not working well with low blood pressure and fast heart rate, these patients, again, will feel much better. The 13th point on the map is GI disorders. People will come in sometimes with diarrhea, they'll come in with constipation, they'll have inflammation in the colon, they'll have parasites. You have to address leaky gut, food sensitivities, dysbiosis, where the microbiome, the bacteria that are present in the gut, are out of balance, and there are bacteria in the gut called bifidobacterium, which are responsible for decreasing inflammation. So if you don't have the right balance of bacteria in the colon, this also may be responsible for some of the inflammation in the body. The 14th point is people will come in occasionally with elevated liver functions. And normally as an internist, I would think about looking for some of the most common reasons why people have elevated liver functions, like an iron overload, hemochromatosis, or copper overload, Wilson's disease, or viral infections like hepatitis B or C, or alpha-1 antitrypsin deficiency. But tick-borne infections like Lyme disease also can raise liver functions. So it's necessary to always keep in mind that even Q fever can cause a chronic hepatitis. The 15th point on the MSIDS map are pain syndromes. Lyme will cause every different type of pain syndrome that you can imagine. It will cause chest pain due to costochondritis with inflammation in the chest wall. People will go to cardiologists saying they have chest pain, and their echocardiograms are normal. People also get neuropathy, pain in different nerves in their body, and people are on narcotics like morphine or Duragesic patches because the pain is so bad. And I have discovered that by treating Lyme disease and associated co-infections and using certain medication like low-dose naltrexone and anti-inflammatory herbs, we can get them off of their narcotics and relieve their pain. And the 16th and final point on the MSIDS map is deconditioning. When you have been sick with Lyme and associated tick-borne disorders for a long period of time, you're very tired, you've been in bed for a long time, you're extremely deconditioned. So you need to go back and do physical therapy and to work the body slowly with the muscle groups getting into form. And we found that by getting people into physical therapy and getting them into conditioning programs, people will feel much better over time. So again, this 16-point Lyme MSIDS map is the key to getting people better with Lyme and associated tick-borne diseases. After seeing 12,000 chronically ill people with Lyme disease in the last 27 years, I have found that people will come in and have 4 of these reasons on the MSIDS map as to why they're staying sick, or some may have 8, or some may have 10. The point is, it's individualized. The job of each physician is to find which of these points on the MSIDS map are responsible for the chronic illness, because what we're discussing is a paradigm shift in medicine. We have been taught that there is generally one cause for one disease, Pasteur's postulate. What I'm discussing with you today is that in the 21st century, the chronic diseases that people are coming in with are no longer due to one problem, but to multiple etiologies which are overlapping at the same point in time. When we look at the level of evidence behind the Infectious Disease Society of America practice guidelines, we find that more than half of the current recommendations of the IDSA are based on level 3 evidence only. What this means is they're not based on hard scientific evidence, but only the opinions of the authors. And until more data from well-designed controlled clinical trials become available, physicians should remain cautious when using current guidelines as the sole source for guiding patients' care decisions. And this was published in the Archives of Internal Medicine back in 2011. The CDC also just came out with data last year in 2013 and confirmed what I just told you, that over 50% of physicians in the United States do not treat Lyme disease using IDSA guidelines, but rather use ILADS guidelines and treat for longer periods of time. This is important because there's a controversy right now about how long to treat Lyme disease. And politically, in the United States, many doctors lose their license for treating Lyme disease for longer periods of time. I would not want the same situation to exist in Europe, because I have found that longer treatment trials of antibiotics do help patients with Lyme disease and associated tick-borne disorders. And as you can see from the CDC data, the majority of the doctors in the United States are treating for longer periods of time. There is a lot of controversy whether Lyme persists in the body. I'm showing you on this slide 6 studies published in the peer-reviewed scientific literature that Borrelia burgdorferi can persist despite intensive antibiotics. And here's another slide showing you 5 more studies that Borrelia can persist despite intensive antibiotics. And another slide showing you Borrelia persisting, another 5 studies. And here's 6 more studies showing you that Lyme can persist in the body. And the last one on here was done by Monica Embers, where they showed persistence of Borrelia in the rhesus macaque monkeys. And it's now been proven in the animal models, recently also proven in humans. In 2011, the CDC surveillance case definition said you had Lyme disease if you had an EM rash, or you had one objective manifestation such as a meningitis, a cranial neuropathy such as Bell's palsy, a swollen joint with arthritis, or a cardiac conduction block. That was also laboratory confirmed. But you must realize that the surveillance case definition was developed for national reporting of Lyme disease, and the CDC said it was never intended to be used in a clinical diagnosis. Well, why has it been used as a clinical diagnosis? Because insurance companies have taken this definition and used it in clinical practice, and unfortunately, it does not work. In the serology for early Lyme disease, you will only get a positive blood test in 20 to 50% of the cases, and serology may remain negative if you give antibiotic treatment early in the course. So diagnosis is clinical at this stage early on. We therefore need to change the CDC and the UCALB criteria. The UCALB criteria was established in Europe several years ago. The IDSA and the European Concerted Action on Lyme Borreliosis have recommended this two-tiered testing approach. And according to these guidelines, an immunoblot is not to be performed if the ELISA is negative, despite the fact that there is poor sensitivity of the ELISA tests, which range from 34 to 70.5%. The effect of this is if you use the UCALB criteria and the CDC criteria, you will miss roughly half of the people with Lyme disease in Belgium and in Europe. And I have 3 scientific references below that show you that the sensitivity of this testing is inadequate to pick up Lyme disease. You're going to miss it anywhere between 30 to 60% of the time using the two-tiered criteria. It's very important to understand, when you do send off a test for Lyme disease, what are the Borrelia-specific bands on a Western blot? In other words, how do you know, looking at the tests, that someone really has been exposed to Lyme disease? Well, there are several proteins or bands on a Western blot that tells you that someone has been exposed to Borrelia burgdorferi, the agent of Lyme disease. These are the 23 band, the outer surface protein C, the 31 band, the outer surface protein A, the 34 band, the outer surface protein B, the 39 band, and the 8393 KDA bands, and this was published by Ma et al. On significance of the bands on the Western blot. So if a patient comes to you with the proper clinical symptoms, they tell you that they have good days and bad days. Their muscle pain and joint pain migrates around the body. Their nerve pain, their tingling, numbness, and burning moves around the body. They have memory and concentration problems, where their B12 levels and their folic acid levels and their thyroids are normal. And you've screened them for all other diseases, and you can't find a reason why they're tired, why they have muscle and joint pain, why their memory's not working, why they're not falling asleep. And you've done a Western blot, and any one of these bands shows up positive, that would imply that they've been exposed to Borrelia burgdorferi, because the only way they could get these bands on a Western blot is exposure to Lyme disease. I have developed a screening questionnaire which is in my book. And what I'm going to suggest to you is that the screening questionnaire be used by different medical professionals. For example, Lyme disease can be transmitted from the mother to the developing fetus. I would suggest that the OBGYNs use the screening questionnaire to see whether a pregnant woman has been exposed to Lyme disease and whether the developing fetus is at risk. This questionnaire could also be used by general practitioners, by internists, by neurologists who see people with neurological symptoms, rheumatologists, where people come in thinking that they have rheumatoid arthritis or lupus, because Lyme is the great imitator and imitates these different diseases. You would use this screening questionnaire as a way to screen patients initially before sending off the blood tests, so that you do not have to spend a tremendous amount of money screening people when they may not have symptoms that are consistent with Lyme and associated tick-borne disorders. Here is an example of my questionnaire. It is in my book starting on page 32. And I would suggest printing off this questionnaire and validating it in Belgium by the internists, by the neurologists, by the rheumatologists, by the OBGYNs, have people fill this out and figure out in Belgium, what is your score to have Lyme disease? If you screen these patients using the 38-item questionnaire and establish a broad differential diagnosis, you will be able to figure out why these people stay chronically ill. You add up the points on this questionnaire, and you come up with a score. What we have found in my medical practice in screening 100 patients who came with chronic Lyme disease and MSIDS is that with a score of 46 or higher, they were 2 standard deviations above the mean, meaning they had a very high likelihood of having been exposed to Lyme and associated tick-borne disorders. So you can use this questionnaire as an initial screening tool to see whether you should be sending out tests for Lyme disease, understanding that your ELISA test is unreliable and you must understand how to interpret the Western blot. The Lyme Task Force recommendations were just released by Dr. Ahern and Chris Fisk from the Lyme Action Network. And they showed that if you look at the economic impact, 2 recent studies have focused on assessing the burden of disease, which is measured with financial costs associated with the illness. Conducted among patients with Lyme disease, the studies found that the economics of Lyme are staggering, and the projected future impact will be even more stunning if large-scale reformative actions are not undertaken immediately to rein in the expanding problem. In the first study, conducted in 2006 by Zhang and colleagues, and adjusted in 2013 for inflation, the researchers found that the mean annual cost of illness was strikingly different depending upon the speed with which the diagnosis was made. The costs were $400 if someone was treated at the time of the initial tick bite, $1,658 per year per patient for early Lyme disease if caught in the early stages. But it went up to $20,502 per year per patient for late-stage Lyme disease year after year after year. So clearly these numbers show that if you want to keep down suffering and keep down costs, you must diagnose and treat this disease early on. All of this is discussed in my book, Why Can't I Get Better? This was published through St. Martin's Press in November 2013. It made it onto the New York Times bestseller list within the first month. It's a 526-page hardcover book, and it describes in detail everything that I just described to you on the 16-point Lyme MSIDS map, which shows how I solve the mystery of Lyme disease and how I get people better. I've worked at this as a medical detective for the last 27 years, and all of this is in my book, and I hope that you will read it and the physicians will use this as a new model for treating chronic disease, because this is what I'm finding has been effective in getting my patients better. My book, which came out in November 2013 through St. Martin's Press, is now going to be translated into French. It's coming out by Terry Sukar Publishing this June 2014. Douleur, fatigue, confusion, pourquoi je m'en sors pas? Résoudre le mystère de Lyme et les maladies chroniques inexpliquées. So for those of you who do not read English well, it will be coming out in the French language in the next 2 to 3 months. I look forward to coming to Belgium and sharing this information in detail with you, and again being a consultant for European countries. I will be in Norway this summer, training doctors and speaking to the Norwegian government at the end of May, and I will be in France in Strasbourg, doing a training for doctors in Strasbourg, 8 hours in French, for those of you who are francophone. I'll be speaking in French, explaining the entire Lyme MSIDS model. So it's been a great pleasure being with you today and sharing this information. Wisdom is the marriage of knowledge and experience bound by compassion. If we want to solve this epidemic, science has already bridged the gap. As I've shown you today, science has already shown us most of the answers. But we need to have compassion for these sick and suffering patients. We need to be open-minded and realize that we don't have all the answers, but the 16-point MSIDS model gives us many of the answers that we've been looking for, and we need to get together and have forums where we bring everyone together to discuss this worldwide epidemic, how to lower costs, how to lower disability, and how to improve outcomes for these patients who've been to 10 to 20 doctors without answers. Thank you so much for your attention. It's been a great pleasure.